Hello and welcome. Today, we're taking a deep dive into a pathogen that absolutely has to be on every clinical microbiologist radar, Bordetella parapertussis. Now, this whole explainer is sourced from a pretty comprehensive Gemini deep search. And hey, for those of you who want to dig into the primary literature, all the sources are right there for you in the accompanying notebook document.
So we've laid this out to follow the classic path from bench to bedside. We're going to start with the bug itself, then we'll walk through how to spot it in the lab, tackle some diagnostic challenges, then get into the clinical side of things, what the treatment guidelines look like, and finally wrap up with the big picture public health stuff. All right, let's kick things off with section 1. We're talking about the other whooping cough and, introducing a pathogen that has a few clever tricks up its sleeve, especially when it comes to vaccines.
So here's the fundamental puzzle, right? You've got this organism, it causes an illness that looks just like whooping cough, it spreads easily, but, and this is the kicker, it completely sidesteps our number one tool for prevention, the vaccine. And that, right there, is why getting the identification right is so critical from a public health standpoint. So let's get a formal definition on the table. Bordetella parapertussis is a gram-negative coccobacillus, a short, rod-shaped bacterium, and it causes this pertussis-like syndrome. The really crucial difference, though, is that the disease is usually milder, and the key reason for that, from a microbiology perspective, is that it doesn't produce an active pertussis toxin.
Now, its evolutionary strategy is actually fascinating. It seems to have evolved from an ancestor similar to Bordetella bronchiseptica, but it did something really clever along the way. Unlike Bordetella pertussis, it held onto its surface O-antigen. Think of this O-antigen as an immunological shield, a kind of invisibility cloak that blocks antibodies from a previous pertussis infection or a vaccine. This strongly suggests it found its niche by thriving in populations that were already immune to its more famous cousin. Okay, let's head over to the bench for section 2, identification in the laboratory. We'll go from the gram stain all the way to those key biochemical tests that give it away. So what are we looking for on the plate? Well, you'll see a gram-negative coccobacillus, but a huge clue is that it grows much faster than Bordetella pertussis. We're talking 2 to 3 days, not a week. And while it might have that classic mercury drop look on Regan Low, the real giveaway is its ability to grow on simple nutrient agar. When it does, it often produces this unique brownish pigment. That's something Bordetella pertussis just flat out can't do. This table right here is pretty much your key for telling these species apart. Just look, you can work right down the list. Growth rate immediately separates Bordetella pertussis. Then, growth on nutrient agar groups Bordetella parapertussis with Bordetella bronchiseptica. And finally, the biochemicals nail the ID. That negative oxidase and positive urease, that's your definitive answer for Bordetella parapertussis. So, let's boil it all down. If you need to remember just 2 definitive spot tests to distinguish Bordetella parapertussis from Bordetella pertussis, these are the 2. Bordetella parapertussis is oxidase negative and rapidly urease positive. It's clean, it's simple, and it's a super reliable way to tell them apart right there on the bench. Okay, let's move on to section 3, because this is where things can get a little more complicated. We're looking at modern diagnostics and some very real challenges with resistance testing, particularly what I like to call the EUCAST guideline gap. So while culture is absolutely essential for that final, definitive species-level confirmation, molecular methods are really the gold standard. Multi-target PCRs that are designed to find those species-specific insertion sequences, like IS-1001 for Bordetella parapertussis, they give you that unambiguous answer that's so important for surveillance. Which, of course, brings us to a really critical question for patient care. Once we've identified it, how do we actually help guide treatment? How do we figure out its antimicrobial susceptibility? And this is where we hit a pretty big wall. This quote here really highlights a major gap in our toolkit. EUCAST, one of our key standards organizations, hasn't published any specific clinical MIC breakpoints for Bordetella parapertussis. That leaves labs in a tough spot without clear, official guidance on how to interpret susceptibility results. And this slide shows a classic lab pitfall that can make a tricky situation even worse. See, if a lab tries to run susceptibility testing directly on a charcoal-based medium, like Regan Low, the charcoal itself can actually bind to and inactivate the antibiotic. This gives you falsely high MICs, making a bug that's actually susceptible look resistant. And that, of course, can lead to clinicians getting the wrong information and choosing the wrong treatment. So now let's transition from the lab bench over to the bedside for section 4. We're talking clinical syndromes. And while the disease is typically milder, it definitely still poses some significant threats. The clinical picture really does mirror classic whooping cough. You can see all the hallmark symptoms, that long drawn-out cough, the characteristic whoop, but in general, they're less severe and the illness doesn't last as long. Transmission is through respiratory droplets, and importantly for infection control, an infected person is considered non-infectious after 5 days of the right antibiotic therapy. But let's be clear, milder does not mean harmless. Not at all. For infants under 6 months old, this disease can absolutely be severe enough to land them in the hospital. And in immunocompromised patients, you can see these rare but really dangerous invasive diseases like bacteremia. For these groups, getting an accurate and fast diagnosis is absolutely critical.
Okay, so how do we treat it? Let's jump into section 5. Because we don't have specific guidelines for Bordetella parapertussis, our approach is really to extrapolate from what we already know works for Bordetella pertussis.
If we take a look at the Dutch SWAB guidelines, you can see they take a syndromic approach. Basically, if it looks like pertussis, they treat it the same way. There's a clear preference for macrolides, and you can see why they like azithromycin. It's a simple 3-day course. It's also interesting to note the specific recommendation of clarithromycin for the absolute youngest infants. And the international guidelines from the CDC, they pretty much echo that macrolide preference. Azithromycin is the go-to drug for almost all age groups, usually for a 5-day course. You'll see trimethoprim sulfamethotrexate listed as a key alternative, which is really important for patients who have macrolide allergies or can't tolerate them.
Now, when it comes to kids, there are some absolutely critical points to keep in mind. Treatment is non-negotiable for all infants under 6 months. And while azithromycin is preferred even in newborns, clinicians have to watch for a small but very real risk of something called infantile hypertrophic pyloric stenosis, or IHPS. That risk is actually higher with erythromycin, which is why we generally avoid it now. And finally, trimethoprim sulfamethoxazole is a no-go for any infant under 2 months old. And for our final section, let's zoom out to the bigger picture, prevention and public health, and what I think of as the surveillance blind spot. Infection control measures are thankfully pretty straightforward. For hospitalized patients, you're going to want to implement droplet precautions. You can stop those after 5 full days of effective antibiotic therapy. And you should definitely consider post-exposure prophylaxis, or PEP, with the same antibiotics for high-risk contacts to really break that chain of transmission. This is a stark takeaway. We have to be crystal clear about this. The incredibly effective pertussis vaccines that we rely on every single day, they offer next to no cross-protection against Bordetella parapertussis. It completely evades that entire line of defense. And this leads us to our final and I think pretty provocative thought. As we get better and better at suppressing Bordetella pertussis with our vaccines, are we basically just clearing the field for Bordetella parapertussis to take over? Is this vaccine pressure inadvertently selecting for its rise, potentially making it the main cause of whooping cough in highly vaccinated populations? It's a really critical question for all of our surveillance programs. You know, this surveillance challenge is a huge ongoing issue in microbiology. So what are your thoughts on this? How does your lab handle it? We'd love to hear your expertise, so share it in the comments below. And hey, don't forget to subscribe for more explainers just like this one. Thanks for watching.